So maybe I'll
Hey,
just
Fred.
do a very, oh,
Yeah. Oh, go ahead. I'm just saying hi.
so I just wanted to have a brief introduction and thank you to Dr. Fred Barker, who's joining us today from MGH, and who we thought of to help with this lecture series because he gave a really stellar talk actually at the K12 meeting and has given several similar talks about just considering the fundamentals of how we design clinical trials to come with the outcomes that we originally intending them to. And I think when I first heard the lecture, I thought, wow, this is really instrumental. Everyone should learn this. And thank goodness my trial was not highlighted as one of the ones that was fundamentally flawed. So that's one of my ultimate goals, sir, is to not end up in one of your presentations to highlight all the things I thought I should have thought of ahead of time. So with that, I just want to say thank you so much for joining us. And we're really looking forward to your talk and discussion.
Thank you. I, I I really try hard not to feature people's talks except in a laudatory fashion if they're going to be at the talk. Can you see the screen there?
All good.
How's that? Okay, so this is a talk that kind of descends a little bit from a talk I gave during the pandemic to the Skull-Based Society. So you see remnants of that here and there, but for that audience, I thought, well, the diseases that skull-based surgeons deal with are for the most part very rare, and so there's although we still end every paper with the sentence randomized trials will be necessary. We're never going to see randomized trials in most of those tumors or in most of the topics that we're interested in. And similarly, when you're early in your career, you don't necessarily have the ability to conduct randomized trials. And most of my talks are about how great randomized trials are. Here's an example. During COVID, with only 1 out of every million patients who caught COVID during the pandemic enrolled in a clinical trial, we demonstrated very conclusively what works, like the various vaccines work like crazy. I had never seen a graph like this. The control patients just get it and get it and get it. And the vaccine patients, after day 9, hardly anybody gets COVID. And hydroxychloroquine, on the other hand, very clearly does not work. And it's interesting, if you look at the numbers at risk here, I didn't notice this till today, this is a biased randomization. 2 patients were randomized to usual care for every patient that got hydroxychloroquine, which suggests that the investigators thought that hydroxychloroquine was probably harmful. And when randomized trials are finished, and especially when they have a conclusion that's favorable to doing more surgery, they really move the needle in terms of the way people practice. So these 2 carotid endarterectomy trials more or less doubled the number of carotid endarterectomies done in the United States over about a 3-year period in the late 1990s. And so if I had $1 for every resident applicant who had cured 10 mice of glioblastoma, and we asked them, what would you do next? And they say, well, we need to do a randomized trial. There are some problems with that. The first of which is that this figure is a little outdated. A phase 3 randomized trial of a drug for brain tumor in the 21st century costs about $30 million. And very few people have that kind of money to spend. You can't ask your your department chair for this kind of money. And people who have $30 million, funding agencies are very unlikely to give it to you unless you have a very conclusive set of data that suggest that the trial is going to work. And so where do those data come from? Well, this is why our literature, despite the fact that randomized trials are great, only about 1.5% of the articles in our magazines are randomized trials. And really the core of the neurosurgical literature is prospective and retrospective series and case series and even case reports and animal studies, which for many purposes can be treated the same as a pilot phase clinical trial. So how much data is really enough? How many patients do you need to see and collect in your study? And the truth is that neurosurgery is a conglomeration, like a cobblestone construction made up of a bunch of rare diseases. And most of them would meet the US Congress definition of a rare disease, as set in 1983 for the Orphan Drug Act, 200,000 persons in the US population. Well, that's a lot. That's almost 100 for every practicing neurosurgeon in the US. And there aren't that many disorders that have a prevalence like that, with the exception of stroke, spinal degenerative disorders, and some of the most common intracranial tumors, including pituitary tumors and meningiomas. So what is the problem? The problem is there's not enough data, and how do we make the most out of what we have, and how do we recognize the limitations of what we are able to do because of this constraint? How do we get the most out of the existing data, and how are the best ways to go about getting more data, particularly early in your career? So most neurosurgical papers are not somebody who sets out to say, I'm going to clip basilar tip aneurysms for the next 5 years, and then I'm going to make a report, and I'm going to do a power calculation, and I'm going to say that I'm going to reduce the mortality by 10% or 30%, and then I'll have enough power for my study to be worthwhile. Most are more like, let's look at the last 5 years. Let's look at the patients I've operated on in my career, or since I started my prospective database 5 years ago. We must have enough patients by now. And virtually no neurosurgical papers contain a sentence or a paragraph telling you about the statistical power with which the study was designed. So because of the reasons that I mentioned, our papers tend to report small series. I looked this morning at the most recent print issue of the Journal of Neurosurgery, 26 articles that I considered eligible for this, and the median sample size was 107 with as few as 4. And this was an important clinical trial. It's not a paper to be sneezed at. Another paper with 200,000, obviously this is coming from the national inpatient sample. And one of the things we'll talk about today is how power does not come from the number of patients, but from the number of events. And that number is always less than the total number. For a binary endpoint, it's less than 50% of the total number, because the power comes from the smaller of the two outcomes. And the median number of events, or for a shortcut, the number of events in this median study was either 33 or 9, depending on the two. So we'll talk about what that means for what you can and can't do with the data. And those numbers are better than you usually see for things like SNUC and juvenile angiofibroma, esthesioneuroblastoma, chordoma, chondrosarcoma. You rarely see 100 patients with these diagnoses in a single paper. So what is power? Power is the ability to reject the null hypothesis when the null hypothesis is actually false. It depends on the data type, on the difference between the two groups, the true difference, and the size of the two groups. And all else being equal, if you have a binary outcome like response, no response, gross total resection, subtotal resection, power is maximized when the comparison groups are the same size. This is why most randomized trials are randomized 1-to-1. And when the difference between groups in the percentage of the outcome is large. And you would like a power of 80% or 90% to have a reasonable confidence of not missing. And this is sort of the confusion matrix. This is the power, is the sum of the correct, and the false positives. And as the difference in the true proportion of outcomes between the two events increases, the power increases. So if you have a 60% difference between the two groups, to get to 80% power, you can do that with 40 patients. But if you truly have a 40% difference, then you're in a much worse situation. You're going to need thousands of patients to get to the difference. And as I mentioned, neurosurgical studies rarely report the power. So the consequence is that a lot of small studies fail to reach a positive outcome, and therefore imply that there is no difference between the two groups. And in a long career of reviewing neurosurgical papers, this is, I believe, the most frequent error in submitted and published neurosurgical papers, is when the investigators report no difference between two groups, only with a p-value. So, and sometimes just p greater than 0.05. and they call it a negative study, and they say it doesn't matter which of these two treatments you employ because the outcomes are the same. So here's an example, tuberculum meningioma resection, CSF leak rates, 2% in 50 patients treated with terminal craniotomy, 8% in 25 patients treated endonasally, and no significant difference with a P of 0.25 was the abstract conclusion. And yet, if you look at these numbers, this is a 4 times higher CSF leak rate in the endonasal, which we kind of have to suspect is true, or a risk difference of 6% between 2 and 8 minus 2, one additional CSF leak for every 17 patients who has the operation. And those are clinically meaningful differences. So you could report this as a risk ratio of 4 or a risk difference of 6. But the important thing is that you would include these confidence intervals on the point measurement being the actual value that you observed of the risk ratio or risk difference. But here you can see that you can't exclude a 15% higher CSF leak rate in the endonasal group or a 42 times higher rate in the endonasal group, both of which are obviously clinically very significant. So the only remedy for this is always to report confidence intervals on any quantity that you report in a neurosurgical paper. And if you think that this is something that other people do and you don't, or that nobody does, or that I'm getting upset about nothing, I went through 2 issues of the Journal of Neurosurgery, July and August of 2023, for a talk last fall. And 75% of the articles in those 2 issues had a negative comparison reported in the abstract text or table with a p-value, but no confidence intervals. So this is not something rare. This is the norm in our literature. And this is how easy it is to get the confidence intervals. There's a web calculator. In fact, there's about 5 web calculators where any statistics program will do this for you. Now, this is something I learned when I was a resident that was a little bit of a sidetrack, but it was so useful to me through my career. What about if something never happens, if you've never observed an event? Is there a confidence interval for that? And the answer is yes. And I saw a AANS talk where an audience member got up and said, well, I read your paper and you said you'd done this operation 15 times with no complications, but that's not very impressive. And the speaker said, well, we've done it 100 times now, and the same complication still has never happened. Now, how much more impressive is that? Well, the rule of thumb is that if you've done something 100 times and something has never happened, the upper limit of the confidence interval is just 3 over 100, 3%. Same with 15 complications. The rule is 3 over 15, which is 20%. So you just take the number 3 and divide it by the number of observations, and that's the upper limit of the confidence interval. Now, how about a slightly more complicated situation, but something that you see in almost every paper when surgeons are making observations in a clinical scenario and trying to develop a risk model. So, okay, what factors predict CSF leak after tuberculum meningioma? Well, you might think BMI, you might think prior radiation, you might think a larger opening in the skull base, a high flow CSF leak during the operation. And there might be 10 or 20 or 30, it's not unusual to see up to 50 predictors tested in looking at a certain number of events. And the rule of thumb here is that you need to have 10 times more events than you test predictors for your model to remain stable. So, and some people say up to 25, and machine learning is not a solution for this. There are papers showing that probably even more events per predictor are needed. But unfortunately, our papers I've seen as low as 0.1 event per predictor tested. So 10 predictors tested for every event observed by the investigators. And again, looking at these same 2 issues of the Journal of Neurosurgery, there were 21 logistic regression models, and 81% of them used less than 10 events per variable tested. So again, the norm in our literature is poor practice, and the median events per variable was only 3. So one of the main answers to the question, the age-old question, why do so many prognostic factors pan out, when somebody else tries to rely on your work or reproduce it, verify it, it often doesn't pan out because it was a false positive. So how can you maximize power? Well, we see a lot of binary endpoints, alive at 6 months versus dead, tumor progressed at 6 months, gross total resection, subtotal resection. But this is the least powerful form of endpoint. And any more information that you can get on the event, such as an ordinal scale, like a Glasgow outcome scale, a continuous outcome scale, including time to event, like median survival or overall survival, progression-free survival. These are far more powerful per individual in the study than a binary endpoint. And of course, the power is greatest when the difference between the two groups, the true difference, is high. You can improve on the power by matching or adjusting between treatment and control. And there are special designs for very rare outcomes, of which we'll talk about the case control outcome. One way you can maximize power is you can make the difference bigger between the two groups. And you see this a lot in stroke studies. In CABG studies, you'll have MI or death is the composite outcome. In stroke studies, you'll see stroke or death. And there are some potential problems with this. If you see a paper using the national inpatient sample that has a composite endpoint of complications, for example, by far the most common complication usually in those endpoints is UTI. So you'll see people trying to say high volume hospitals have less complications when it's the analysis is really being driven by the UTI rate. And that's not how any of us would choose our hospital or our surgeon for our operation. So the individual endpoints that go together to make up the composite should be of relatively comparable clinical severity. So MI, stroke, or death in a carotid endarterectomy or a carotid stenting trial would be a good example of a well-constructed outcome. Any violation of that sort of rule and your results may be skewed by a relatively clinically unimportant driver of the composite. So the other rule of thumb is you don't want to combine safety and effectiveness endpoints because the more aggressive therapies tend to increase the safety events and increase the effectiveness endpoints. So canceling each other out and potentially missing a net clinical benefit. A continuous endpoint will have more power. Time to event is more powerful than a landmark analysis like survival at a landmark. For instance, 6 months is very common when it could be measured accurately. So quality of life, neurocognitive, functional status, if these things can be measured accurately, they're very powerful potential endpoints. The problem is that these tend to be expensive to measure and have a high non-compliance rate because brain tumor patients get tired of filling out quality of life forms every 6 weeks for months or years at a time. When I say measurement may be inaccurate, this is what a progression-free survival looks like in a trial where you get an MRI every 6 weeks, which is pretty frequently, right? To get an MRI much more frequently than that would be pretty burdensome to patients, but you've lost 20% of patients right here at your first scan, and then another 30% of patients at the next scan. So this is hardly a continuous outcome. This might as well be treated as an ordinal outcome. Many people take a continuous outcome, let's just say blood glucose, or a continuous covariate, and dichotomize it, or age greater than or less than 65 would be a good example of this. Tumor size greater than 3 centimeters for acoustic neuroma. And you lump them into the two categories, usually somewhere around the median, and you compare the two categories. This loses a lot of information. And the other thing is that people usually do this one of two ways, or one of three ways. One is the way everybody else does it. The second is you choose the median. And the third is you try every single possible cut point and you choose the one that has the lowest p-value. And what this does is because of the multiple comparisons problem, this is a worthless endpoint that actually has no prognostic value in this study. But by testing every possible cut point, there's this one that just by the play of chance, and usually it's around the median, has the highest p-value for comparing the two groups. So this generates a spurious p-value of p less than 0.01 for something where the p-value really ought to be up around 1. So this is a really serious mistake, and you see it a lot. This paper is from the 1980s. You still see it a lot in the neurosurgical literature. Something to guard against. So what about, you have a limited number of patients. What about more events per patient? There's a little bit of a problem here if you're looking, for instance, at both eyes in a trial of a drug against macular degeneration, that the two eyes are likely to have the same outcome. The two eyes are likely to be highly correlated. And so you have to adjust for that in your statistical assessment plan. But there are cases where you can cross over back and forth again and again between two variables, two treatment states. And this has a tremendous amount of power. The problem is that it's not very applicable to surgical treatments. You can't do an operation and then reverse the effect of the operation and then reapply the effect of the operation. You can, with drugs, you can cycle between drug on, drug off, or between two different drugs in a crossover strategy. And the functional surgeons have a real structural advantage here, because it is possible in a blinded fashion to cycle between the on-off state for DBS for different types of treatment. Once the parameters of maximal efficacy have been set, you can go back and forth between on and off in a way that neither the investigator nor the patient knows. And that's a very powerful way to do things. But unfortunately, in tumor, we don't really have any existence of this. And there's an analog of the case control study for rare outcomes that exists when you want to compare harmful exposures. An example of this was Hasty and Tibshirani's article in the New England Journal showing that cell phone use predisposed to traffic accidents while driving. And the only time I've seen this in the neurosurgical literature was whether or not pregnancy causes hemorrhage from cavernous malformations. But there are occasions, and it's a very powerful design when it can be used. You need far fewer patients because you have multiple observations per patient. As I mentioned, you can't treat the two eyes as independent observations. We don't have as big a problem with that as the ophthalmologists do. But the usual thing that we do is we say, well, we've only got 50 patients. And so what we're going to look for is 3 times longer survival. What happens with this? Well, the first is that almost no treatments really work that way. Penicillin for pneumonia, the kind of jokey example from the Lancet of jumping out of airplanes with or without a parachute. But most things that we do, temozolomide, which we think of as pretty effective, the hazard ratio is only 0.6, not 0.5 or 0.25. Novacure is same ballpark. Gliadel, same ballpark. So if you plan a trial that looks for a very large difference, not only is your false negative rate high, but it also makes false positives more likely. And ordinarily, you can sharpen up your estimate of a treatment effect by matching the patients or adjusting for confounding factors, like using a propensity score matching scheme to match patients by their suitability for 2 different treatments, or an adjustment for confounders. This is the original Gliadel trial, again from the 90s, a large randomized trial reported in the Lancet. And the unadjusted hazard ratio was 0.83 with a p-value of 0.19, but the adjusted hazard ratio, adjusting for things like Karnofsky scale, whether or not whole brain, that tells you something about the treatment era here, whether or not whole brain or local radiation was used. The adjusted hazard ratio was much smaller, about 2/3, and the p-value was much more optimistic. Case control studies. This is extremely powerful design, but we usually we call studies case control studies that are not case control studies. What a case control study means is you've seen 5 patients who have experienced a very rare event, and then you select healthy controls that you match to them, for example, by age or by everything that you can that's not the exposure that you think is harmful. So it's a design that epidemiologists use to look for etiology of infectious diseases or cancers or studies of clustering, things like this. So it doesn't matter how rare the outcome is. If you have a means of capturing the patients that it happens to, you can then match them to patients from the population that they're drawn from. And the problem is that in neurosurgery, we tend to call things case control studies because they have cases and they also have controls, which is almost every study that we publish. And only about half of studies that are referred to in the title or abstract as case control studies are true case control studies. That said, how else would you go about proving that occupational exposure to hardwood dust causes nasal adenocarcinoma? So what you've done here is you've collected 30 or 50 patients who have nasal adenocarcinoma. You've asked them how many have an occupational exposure to hardwood dust, and then you go and you get 50 patients who are healthy, who don't have the disease, and ask them how many of them have occupational exposure. And it's a very, very highly effective technique. It's been used to link dental X-ray history to meningiomas, intracranial schwannomas to exposure to the atomic bomb in Hiroshima and Nagasaki. And cell phone use in malignant glioma, it's more or less been used to rule that out. And you only need 5 matched controls per case to have 80% of the power of studying the entire population that those cases were drawn from. So you can really be economical in your use. But unfortunately, its main use is in studying harmful exposures and the etiology of disease, not in studying treatment effect. And I'll just toss this out. It would take a little too long to go through the math. But if you're looking for home runs, most of the positive findings, I mentioned that you're going to overlook a lot of moderately effective treatments, but the mathematics of it works out that the positive predictive value of the trial, if you think of the trial as a diagnostic test, goes down as your target efficacy goes up. So if you're looking for home runs, a lot of your positives are going to be false positives. And unfortunately, that I think is true of our literature. So what do you do if you don't have enough data? Well, obviously you'd like to get some more data, but getting more data may be expensive or it may be difficult because your hospital only sees 3 cases a year. So what can you do in those situations? Well, particularly early in your career, found data are very attractive. These are data that you find without any effort on your part. So you find them in the literature and you call it a meta-analysis, or you find it in a routinely collected administrative database and use that. Let's talk about meta-analysis first. So the 2 big problems with meta-analysis that you should think about every time you read one is garbage in, garbage out, and apples and oranges. So garbage in, garbage out was never actually printed on IBM punch cards the way the myth has it. There's a guy on the internet who has a museum of IBM punch cards, and I even emailed him and asked him, and he said no, that's an urban myth. But you see it a lot in meta-analysis, both in the form of the authors making errors in data extraction, and in the form where the studies are reporting different outcomes that are being treated as the same. So in addition, the data that are published do not necessarily reflect accurately what is happening in the real world. If we went and we did an operation for trigeminal neuralgia, microvascular decompression, and the patient got better afterward, maybe Peter Janetta could report that back in the 60s, but we can't report that today. There has to be something interesting to engage the editors and reviewers' attention. So sort of by design, if it's not something novel, then it's typically better than people would expect. And there may be a lot of doctors out there doing the same thing and getting a result that is what you would expect or worse than what you would expect, who are not publishing it. And this can be actually demonstrated. So question here, how often is retinoblastoma accompanied by a pineoblastoma, so-called trilateral retinoblastoma? And in the largest studies, 600 retinoblastoma patients, the incidence was around 2%, maybe 1% for these large studies. But as the studies get smaller and smaller, the more and more retinoblastomas occurred in the study. So this study here with about 60 patients reported that 13% of them had trilateral retinoblastoma. So this is a form of publication bias. And the true incidence in SEER, unless it's under ascertained, which is possible, is only 0.6%. So even these publications are probably overestimating it. And in fact, our case reports in our journals probably underestimate mortality or morbidity by about a factor of 2 or 2.5. So this National Registry mortality for Whipple resections in general surgery, 2.4 times higher reported mortality than in published case series. And if you look at CABG studies, bypass surgery, when the study was smaller than 100 patients, remember the median size in our journals is about 100 patients. When studies smaller than 100 patients, 98% of them reported a mortality lower than the national registry value. So it's a fair guess that most of our studies are underestimating bad things and overestimating good things. How about data extraction errors? Well, you say, well, this study did it very carefully. They had 2 authors read, and they had a 3rd author that reconciled any differences. There are still, I have to tell you from reviewing hundreds of these things, there is a huge problem with inexperienced authors who extract the data improperly. So I didn't see this paper in review. I saw it after it was published. And these are the reported complication rates of microvascular decompression for trigeminal neuralgia. And the red bars are facial paresis or weakness. And take a look at this now. This is my paper. Okay, I know that the true value in that paper was 0. And yet look at the size of the red bar. What's going on there? You're telling me 2% had a complication that I know did not occur in that series. And what complication rate have you ever seen or heard of 25% of microvascular decompression for trigeminal neuralgia being followed by a permanent facial palsy? It just doesn't happen, right? And if you look back at the primary papers, what this is the rate of numbness in these papers, not weakness. And whether this is a language barrier problem or just somebody who, many patients don't understand the difference between numbness and weakness when you ask them about it in the office. It's not an uncommon confusion that people have, but it's really fatal to this study. I mean, you can't do anything with this kind of data. The true incidence in these papers, when I looked them up, was 0.1%, which is off by a factor of 100 from what they reported. And I think the real problem here is that readers hold this in their hands. They have the meta-analysis in their hands, and it takes a certain amount of effort to go look up the 10 papers and check this. And so it just takes you one step away from the reality that actually happened in the clinic to what you think happened, which is always a mistake, getting farther away from the clinic. So what about the heterogeneity problem, the apples and oranges problem? You can combine apples and oranges if what you're looking for is sort of round fruits. But anything other than that, it's really not a very productive way to combine data. So different measures of prognostic factors, different treatments, different ways that surgeons do surgery, except for randomized trials of the same drug with the same output, the same outcome measured using the same scale. Virtually all papers have got heterogeneity, not just because of the play of chance, but because there are true differences in the outcomes of the studies. And in a meta-analysis, we report this as an I-squared value, and the I-squared can go from 0% when there's no heterogeneity to the high 90s. I've seen 98, 99%, which is the variation that's observed between the studies that you have in hand that's in excess of what would be expected from chance if those studies were all truly drawn from the same pool. And the higher is worse, so 99% is bad. And even with 0%, the heterogeneity does not have a very high power. It underestimates the true heterogeneity more often than not. So even though PRISMA guidelines require authors to report this, they often don't. Even if it is reported, they'll often go ahead and stuff these data into the Procrustes bed of classical mythology, where everything has to fit into the same size. And in my mind, if the heterogeneity is greater than 80%, you really ought to stop and ask yourself whether pooling these data is a good idea, whether it has any real meaning. So let's stop and think a little bit about what confidence intervals mean. So if you think as a guest, you're going to the Academy meeting, the American Academy of Neurological Surgery, how old are the people going to be that you meet? Well, that's pretty easy. You take the database and you calculate the mean. The mean is 69. So it's an older group. What's the confidence interval on that? Well, the mean is 69, and the confidence interval is pretty tight, 68 to 71. But you'll see that this, when you say, well, how old are the people that I'm going to meet? You want a number that spans something like this. There's going to be some people in their 40s, and there's going to be some people in their 70s and 80s. And this doesn't capture that at all. The pooled, confidence interval on the mean is not what you're asking for when you ask this question. What you're asking in meta-analysis terms is called the prediction interval. So if you just blindly, you're going to go out to the reception and meet an Academy member, that person is likely to be between 51 and 94. So that tells you something. They're not likely to be in their 30s, but it's a broad range. And you see the same sort of thing in the results of a meta-analysis. So this is a paper that I helped design this study. Okay, so this is my mistake as much as anybody's. We were treating patients with recurrent meningiomas that had a specific type of mutation with a FAK inhibitor, a specific drug. And we wanted to compare to a historical benchmark. And so we pulled a historical benchmark, one that's very commonly used, from this literature review from 2014, done by a very distinguished group, most of whom are friends of mine. And the problem is that the way that was done was they took 9 studies with as few as 3 patients or as many as 60, all different drugs, possibly some active, possibly some not, all with different criteria for progression. And they simply added up the number of events and divided by the denominator, which was the sum of the number of the patients. So in 174 patients, they had this many events, and they calculated a percentage progression-free survival that should be expected of 29%, with a pretty tight confidence interval, 23 to 36. And if you remember, we had an 83% progression-free survival. So this is a home run, right? This is 2 or 3 times the expected progressive-free survival rate. Well, the problem is that the heterogeneity here is very high, 76%. And so the answer to the question, what should the next similar study have for its PFS6 rate, is the prediction interval, not the pooled mean. The prediction interval, which runs from 3% to 85%. So our supposed home run of 83% progression-free is actually within the expected value just through the play of chance. And if you look at trials that have used the Cayley benchmark, 5 evaluable trials, all 5 had PFS6 results that exceeded the upper 95% confidence interval of the weighted average as reported in the paper for a historical benchmark. Only one of the 5 exceeded the upper confidence interval for the prediction interval, and not a single objective tumor response was observed in any of these 5 trials. So basically what you have here is a field that's kind of adrift, that is relying on a historical benchmark that really is too insubstantial to be leaned upon. And if you have a new fancy way of doing shunts that you think is going to have a lower failure rate, and you look at this meta-analysis published in World Neurosurgery just about a year ago, Again, the pooled mean for the failure rate is between 18.9 and 19.5%. That's a pretty tight target. You should be able to beat that. And the random effects isn't much broader, but the prediction interval is very broad. So if you think that your method of doing shunts is better than these methods, you have to beat a failure rate of 9%, which is a lot harder than beating a failure rate of 19%. Second time found data is the administrative database. These are typically billing databases like Medicare or hospital discharge databases like the National Inpatient Sample, which is built out of databases that each state requires hospitals to report certain data at discharge. And I'll show you some of the complications here. There are a lot of these that are used in neurosurgery. They all have fairly similar features, except Medicare, the CMS database, which has a lot of clinical detail that the other ones do not. The coding, that first of all, you can have things that are undercoded, like the departmental database captured 97% of cases. This is done at Johns Hopkins, a pretty fancy place. 97% of actual endovascular treatments of aneurysms were captured by the departmental database, but only 30% in the data that were reported to the state, and hence that went to make up the national inpatient sample. The second is that a code like 225.2, benign tumor of meninges, captures everything from this tumor to this tumor, and the morbidity and mortality of treatment of these two tumors is starkly different, and there's no way to tell that from the database. So that risk adjustment using a code like that is very imperfect. And there are events that you would really like to know that are undercoded because they don't affect the bill that the hospital sends to the insurance company. Like, for instance, the obesity rate in patients having shunts for pseudotumor, 13%. Hearing loss in patients with acoustics, 13%. Tinnitus, virtually every patient has tinnitus, 2%, according to the administrative database. Subarachnoid hemorrhage cases admitted, first admission, only 13% were reported to have CT scans. It's because these things don't generate a bill. Now, in the year 2000, the WHO revised its criteria for meningiomas by adding certain criteria that boost something from a grade 1 to a grade 2, from a benign to an atypical. And at this single institution, the University of Alabama, you can see that the rate of atypical diagnosis in meningiomas went from 4% to about 30%. And nationwide, it probably went up from about 5% to about 20%. But you don't get paid any more to take out a meningioma that's grade 2 than you do to get paid for meningioma that's grade 1. So this should have gone up to 20% off the top of the scale, but it didn't budge. In contrary, you wouldn't think that as few as 2% of meningiomas had edema in the adjacent brain, but until 2007, that was the rate in the administrative databases. And then for some reason, all of a sudden, it went up to 20% and kept going straight up. And the reason is in 2007, the way you were paid for craniotomies was changed from DRG 1, 2, or 3 to 25, 26, or 27. And what you get paid for 25 with major complications is twice what you got paid for 27 without complications. And it turned out that the coding change here was, it went from about 100 codes that could get you up to that high paying DRG in the early years to about 6 codes in the later years. And one of those 6 codes was edema, cerebral edema. So that quadrupled and more the rate of reporting that particular code. And for these and many other reasons, it's not uncommon to see really discordant results when you compare real world data, quote unquote, from administrative databases to randomized trials of the same treatment. Discordance and summary overestimation of benefit in routinely collected data. So what's the best solution here? The best solution is to go out and get some more real data. basically from other centers, either through a cooperative agreement or through a registry or through some broader data collecting structure, so that ideally you can develop common data elements and broadly accepted outcome measure definitions and get the kind of granular clinical data that you need to do many of these studies. And here's an example. Mike McDermott thought he had a pretty good grading scale for risk of surgical outcomes after a transcranial versus transsphenoidal approach for tuberculum cellomeningiomas. These centers, one in Italy and the second was UCSF, a major center, only 139 patients, and the publication was in Neurosurgical Focus. And then when he put together a team of collaborators, he had 40 sites. He had almost 1,000 patients. Now that's enough to do propensity score matching and also to get into a much higher impact journal over a 5-year period. And this is a retrospective study at each of these 40 centers. This is not prospective data collection. Neurosurgical registries, NPA, which is affiliated with the AANS and to some degree supported by it. There are registries in tumor, in spine, in traumatic brain injury, in radiosurgery, and in DBS. Trials networks that are supported by the NIH include things like the NRG and the Alliance Cancer Cooperative Groups and the Neurofibromatosis Consortium. And this allowed us from a single case observation in 2016 to progress to a national trial that was open at nearly 100 centers in very short order, and to get 16 patients in relatively quick time, and find that it was nice to have one impressive response, but it was much nicer to demonstrate that every patient who received more than 8 days of the treatment had a major response, the median volumetric response being 91%, and this got into a much better journal. So in summary, the things that you really ought to try to remember about the way we do business: power is not related to the number of patients in the study, but to the number of events that are observed. If you're doing a logistic regression analysis or a machine learning analysis, you really want to target more than 10 events for every predictor that you want to test. So if you have 50 events, you really shouldn't test much more than 5 candidate predictors. So you have to choose more carefully than we've been used to be doing. Using continuous outcomes, particularly a survival outcome where appropriate, maximizes power. Avoiding dichotomizing continuous covariates or outcomes like age or Glasgow outcome scale in stroke or trauma. And always reporting confidence intervals, particularly for a negative study, so that you have transparency in reporting of negative studies. And small data sets mean a home run will be needed, which we hardly ever see. So to detect moderate benefits, get more data, preferably through multi-center studies. So that ends what I have to say, and I'd like to thank you for the invitation, and happy to take any questions.
Thank you so much for that excellent review. And at this point, I'd like to open it to all the participants. Please feel free to use this opportunity to ask any questions you may have.
Dr. Zipfel.
Fred, that was outstanding. I learned something every time I listen to you, and I wish I had just an ounce of statistical understanding that you have. So, but thank you very much for giving this talk. Could you talk about? I'm struck every time you show the Journal of Neurosurgery or other neurosurgical journals that they're kind of that the studies are falling down on some of these kind of basic criteria that we need to use, including confidence intervals and things of that nature. What I mean, shouldn't the journals themselves be policing this in some? Why is this not being fixed? Because you've been talking about this for years. What's the strategy for the journal that could to help us on?
Well, I think that's a complicated issue. Probably the most effective way, but in a way, the most inefficient way is to have the person who sees the article last before it goes out for revision say these things are broken and need to be fixed. But having been in that position for a lot of articles, you don't always remember each of these things, you know. And I think the authors generally know that these things are to be paid attention to. I mean, people generally know that confidence intervals are a good thing rather than a bad thing. I don't think that this is that people are trying to hide things here. I think I think the ideal way to fix it would be at the other end of the pipeline. So during resident education, like if you sat down with the senior author of the paper and you learned these things by example, but you don't have to know these things to pass your boards. I think general surgeons do have to have some knowledge along these lines to pass their boards. And even for somebody who's going into practice and not academics, I think you can't really critically interpret the literature for yourself unless you know some of these things, unless you know that, you know, studying 5 events with 50 predictors is likely to give rise to a non-reproducible result. So I think you can say, well, we could give the reviewers a checklist so that they check all these things. People have done randomized trials of that, and it doesn't work. The reviewers just check off the boxes, and you know, you know how it is, right? I mean, you have a limited amount of time in your life, and some of that time you have to spend eating and sleeping. So it just doesn't work the way you would think it does. We did make a dent in the meta-analysis area because the 2 journals, both Neurosurgery First and then Journal of Neurosurgery more quietly, said, okay, the meta-analysis has to be PRISMA compliant. So there are a lot of these outcome reporting instruments like Moose and EGRET and PRISMA. And it's like a checklist that you go down, and it's these 10 things are important. It's a checklist for the authors, not for the reviewers. And that did improve, like the percentage of meta-analyses that reported heterogeneity in the article improved substantially with that, from like 25% to like 90%. There are still people who check that box on the PRISMA statement and it says not applicable. Okay, that's not one of the options. The option is what page did you do it on? NA is not an allowable answer. There was an abstract at the Skullbase meeting just a couple of weeks ago, which I should have built into the talk. But most of the papers in our literature do not say which of these reporting guidelines they are compliant with. So at neurosurgery, where virtually every paper has to be compliant with one or another of these reporting guidelines, and there's a list of them, only about 25% of the articles said which one they used. So I think you could require that in the article, for example, and that way both the reader and the author kind of know what the expectations are. I think that might be one simple way to do it.
Hey, Fred, thanks again. I just want to echo everything Greg said, but less on the analysis side and more on actually running a clinical trial. Can you speak to the notion of equipoise and preventing crossovers and staying true to allocation, some of the logistics of actually performing these kinds of trials?
Yeah, those are hour-long talks, each. I think to take the crossover question, I mean, we all have sort of PTSD from the sport trial where the randomization was to lumbar discectomy versus no lumbar discectomy. And that also, there's an equipoise aspect to that. And if you think about who went into that randomization, The 25-year-old with a foot drop didn't get randomized in that trial. They got surgery. And the 80-year-old with a little bit of sciatica, once a week didn't get into that trial. So the range of patients in the trial was kind of, limited into the middle. And it's hard to generalize those results to the entire population. The second thing is you can't stop people from, if bed rest doesn't work after 3 weeks, you can't stop them from getting a discectomy, right? They go back to their surgeon. If their surgeon resists it, they go to a different surgeon. So if you have control over the distribution of the therapy, like it's an experimental drug that you can only get, then you can prevent crossover to a certain degree. But if the patient doesn't get the experimental drug and they are able to know that, if there's a failure of blinding or no blinding, then they leave the trial. So you saw that in John Sampson's vaccine trials for EGFRV3, that the control group just disappeared because one of my UCSF rad onc professors used to say that, well, they got randomized to the death arm. And that's what the patient thinks. If you're in a glioblastoma trial and you're getting standard treatment, you entered that trial hoping for something better. And if you know that's the randomization that you got, you're going to leave. So it's really hard, even when it's something that you can't get outside of the trial. You may lose the control group who are seeking other experimental options. So in surgery, there are certain operations that you can only get within the trial, like the VA ran a trial of lung volume reduction surgery for COPD. There was sort of a fad for doing this operation on the lung that kind of decorticated the lung and reduced the volume of the lung. And they basically, CMS said, we're only paying for this in the context of a trial. And so realistically speaking, it's $100,000, $200,000 operation. You could only get it within the context of the trial. But those are unusual situations. What we did with equipoise, actually, in Zoe Gogowala's first trial, this was not my idea, this was Zoe's idea. We were having trouble getting people to accept a randomization to a spondylolisthesis operation with or without fusion. And patients were showing up and they knew ahead of time that they wanted a fusion or they didn't want the fusion. Just like patients show up in my office and radiation is not for them. They don't want to hear about it, even though they would be an excellent candidate. Or they really don't want to hear about surgery. Less often that those patients come to see me, they go see rad onc. And so he was having this problem, and he decided that he would take the individual scan of the patient and show it to a panel of experts, about 8 experts. And they would say, I would do it from the front, but I think that the patient should be randomized, or I don't think the patient should be randomized. And then that information was fed back to the patient. So if the patient understood that 8 national experts had seen their films and didn't know what the right thing was and thought that they should be randomized, the acceptance of randomization, I think, went up from 40% to 80%. But if only 6 of the experts out of the 8 thought it should be randomized, the acceptance was much less. So there was like a dose response almost to the number of experts who themselves expressed equipoise about the case. And the other step is you have to find surgeons who are willing to accept randomization. And that I saw Zoe do this in his second trial. He had a meeting of about 15 of the top spine surgeons in the country. And he showed case after case, and surgeons said, like, no, I would never do a laminoplasty on that. I would never do that from the front. I would never do a posterior fusion for that. And then he would ask for a show of hands, and half of the crowd would do a laminectomy for that, or do it from the front, or do a posterior with fusion. And it was sort of educational. These people had this look of disbelief at first, like, are you serious? That's what you would do? And then they came to realize that people with reputations as powerful as theirs would do the other thing. And so there's sort of an education that you can apply at the patient level and at the surgeon level. And so equipoise can be changed. Equipoise can be modified. It's not like a fixed truth about the world that we're helpless in the face of. You can change it.
Thank you so much for this great discussion and lecture, and I appreciate you all taking the time. I think it's an excellent review and one that I definitely need at least annually. So thanks again, and everyone have a great night.
Thank you. Have a good night.